Welcome to AETCM Emergency Medicine channel. Shall I start?
Yeah.
80-year-old male patient presented with sudden onset of dizziness followed by a syncopal episode about 2 hours back. On initial 10-second assessment, patient drowsy but arousable, oriented, airways patent, no pooling of secretions, no gurgling, breathing saturation is 95% in room air with respiratory rate of 25 per minute and chest has bilateral basal clefts, right more than left. Circulation BP is 120/60 millimeter mercury. Pulse rate is 29 per minute.
Okay, so heart rate is 29.
20.
And BP is?
BP is 120/60.
Okay, and in air under respiratory rate was how much?
Respiratory rate is 24 per minute.
24.
95% saturation.
94. Okay.
At that point, we connected to the cardiac monitor and 2 IV large bore IV cannula inserted. And since the patient is in bradycardia, we give and BP is around 120/60. At that point we have to check for the signs of instability for the patient.
What are the signs of instability?
If the patient is in sign of shock, any signs of shock, hypotension or ischemic chest pain, altered mental status or heart failure.
Okay, acute heart failure, signs of acute heart failure.
Patient,
so that are the signs of
instability.
Instability. So if the patient is in an unstable condition with bradycardia, what will you do?
We'll give injection atropine. We can give 1 mg.
1 mg. How many times you can give atropine?
Maximum dose is 3 mg.
3 mg. Okay.
Between 3 to 5 minutes we can reassess.
So 3 times you can give like 3 to 5 minutes. So here patient is in an unstable or stable or unstable state?
Patient chest has bilateral basal crepitations.
Okay, basal crepitations are there.
And BP is around 120/60. Patient is already known case of hypertension.
And had history of some palpitation also, right? So you gave the patient right now, signs of instability are there and bradycardia is there. So you gave the patient, atropine was given. Okay, and later on?
Later on, we assessed further disabilities. GCS is E3V5M6 and pupil bilateral equivalent reactive, especially febrile with a GRBS 156.
156, okay.
And at that time, we took one 12 lead ECG, CBCRP and BBG.
Okay, you send it. And upon reassessment? On
reassessment, the pulse PR pulse rate is around 29 per minute. 29.
Still, patient is having the same thing, and
second
no
dose
change was. Second dose atropine was
also given.
Okay.
And on ECG, we saw PP and RR interval is same with widened QRS. And also there is a AV dissociation, no association with P and QRS. Okay. And it shows a complete heart block. And at that time, we also
complete heart block was there. So what are the conditions where atropine won't work? In case where will you find it?
Like infraxial heart block cases, atropine won't work. In case of second degree heart block and complete heart block, infraxial. And also if it is transplanted heart, it won't work. And if there is any metabolic abnormalities, any drug-induced heart blocks and all, we have to reverse the condition. We have to treat the cause. Okay,
so drug-induced. What are the main causes for like bradycardia? What are the main causes for bradycardia?
In pathological conditions, physiologically, athletes and also in case of sleep, there will be bradycardia. In case of pathological causes, drug-induced.
Drug-induced. Which are the common drugs that can cause bradycardia?
ACE inhibitors, ARBs, beta blockers.
Beta blocker.
Calcium channel blockers can cause digoxin.
Digoxin. Okay. Then
and any metabolic-induced hypothyroidism, hyperkalemia can cause.
Can hypoxia cause bradycardia?
Hypoxia, hyperperfusion.
Okay. So can MI cause bradycardia?
Yes, MI can cause myocarditis, cardiomyopathy.
Okay, fine. And here, so you did an ECG which was showing complete heart block. So patient was having complete heart block, and you again did the blood gas, right?
Blood gas.
Okay. And how was the blood gas?
Blood gas pH is 7.28 with bicarb 14 and PaCO2 is 32 with potassium 8.3 and creat is 4.8.
So potassium is 8 with the pH of 7.2, bicarb is 14. How much was the lactate?
Lactate is 4.
Lactate was also mildly elevated. Okay, so here you have a hyperkalemia. So here you are you suspecting hyperkalemia induced bradycardia?
Complete heart block.
Okay, what did you do then?
At that time we started the hyperkalemia correction. We give injection calcium gluconate 10 ml 10% over 10 minutes. And
like what is the action of calcium gluconate here?
It will help for the membrane stabilization.
Membrane stabilization. Okay.
And
then
we also done the intracellular shift of the potassium. For that we give injection 25% dextrose plus insulin. That dose is between 10 to 12 units can be given. At that point we give GI bolus and also
so glucose insulin bolus. Actually there is no such like preferred dose. Depending upon patient's sugar levels, we will vary the whole thing, glucose and as insulin we will change. Okay.
If
then
the GRBS is more than 250 we can give insulin alone. If it is less than 250 we can give both insulin
so here
and glucose.
sugars are like how much was the GRBS?
150.
So you are given GA bolus was given. So it will cause shift of the potassium, right, towards the cell. Yeah. Then what else you did?
Then we give nebulization with estalin and the dose is around 5 to 10 mg in 4 ml NS. We can give nebulization for the intracellular shift.
How much will that nebulization shift actually? How will it compare to GA bolus and other one? GA bolus, how much of shift will be there in salbutamol nebulization? Is that significant up to the GA bolus thing, or?
In case of GA bolus, it will be prolonged effect will be there 4 to 6 hours. But in case of nebulized, it will be 2 to 4 hours.
Okay. And little shift will be only there in case of salbutamol nebulization, other than like in insulin, it will be large amount of shift of potassium will be there. Yeah. And after that? And after that,
we to repeat VBG, it shows still hyperkalemia, so we give one more correction. And
one more correction what did you give?
ECG still shows bradycardia, so that we give calcium gluconate, second dose of calcium gluconate.
Second dose of calcium gluconate again was given. How much duration of like action of calcium gluconate is for how much time?
Calcium gluconate is for 1 hour,
30 to 1 hour.
60
okay,
minutes. And we give again nebulization with one more GA bolus. And because of the refractory hyperkalemia, we give one consultation for the nephrology also.
Nephrology was also involved in the case. So here patient had hyperkalemia. So can you elaborate on what are the causes for hyperkalemia? Why did this patient when did you hyperkalemia as such? How much was the creatinine of this patient?
Creatinine of the patient is 4.8.
4.8. So this patient had a listen. How can you explain? Is the patient a CKD patient or IAK? Is it an AK?
This 60-year-old male patient with the non-case of diabetes, hypertension, and dyslipidemia, which present to the ER with sudden onset of lightheadedness and brief loss of consciousness less than 1 minute. And he developed generalized tiredness, chest discomfort, and shortness of breath following which that. And there is no history of stiffening or tonic-clonic movements or uprolling of eyes or involuntary micturition. No history of palpitation, nausea, sweating, or vomiting. No history of weakness of limbs, slurring of speech, or facial deviation. And no history of recent head trauma. Patient has a history of fever and cough for the past 2 days and followed by decreased food intake and constipation for 2 days. So following which we examined the patient, and there is mild bilateral pedal edema with chest has bilateral basal crepitations which shows right-sided more than the left. And we took one chest X-ray also which shows right lower zone casiness. And in CBC CRP the total count is around 14,000 with a CRP of 82.
So patient is having an infection, mostly you are suspecting an LRTA.
Lower respiratory tract infection, which is inducing an AK picture, which leads to elevation of the potassium, and that leads to complete heart.
Okay. Did you do an echo, bedside echo was done, screening echo was done?
Screening echo was done, but no regional wall motion abnormality.
And
there is moderate LV dysfunction.
Moderate LV dysfunction was also fine. Okay.
And when we discuss about the causes of hyperkalemia, any acute illness can be cause this hyperkalemia in this patient. Also, there is history of constipation. So the GA loss of the potassium is also reduced in this patient. And other causes, drug induced can be there. And also CKD patients, there will be impaired potassium excretion. And the drugs will be means AC inhibitors, ARBs, or spironolactones, potassium sparing diuretics, and that are the most common causes.
Any other drugs?
hyperkalemia.
Hyperkalemia causing drugs. Any other?
Thiazide diuretic.
Thiazide diuretics causes hyperkalemia. Hyperkalemia causing drugs.
Hyperkalemia.
Hyperkalemia causing drugs. Trimethoprim is one of the drug which causes hyperkalemia. Can you tell me any other? No, if you don't know, that doesn't matter. We'll move on. Fine. Okay, so that's regarding drugs, right? So what are the other causes? Patient have hyperkalemia because of decreased excretion. Decreased renal excretion can cause hyperkalemia. No? What are the conditions where decreased renal excretion is known?
Renal excretion case of renal failure.
Renal failure, AKI or CKD. Then any other thing? Renal tubular. Which is the renal tubular acidosis? Which renal tubular acidosis causes hyperkalemia? Type 4. Distal renal tubular acidosis. Okay.
The other causes, if a patient has a hyperkalemia, we also check for whether it is a pseudo hyperkalemia. In case of tourniquet use or hemolysis in vitro, or leukocytosis or thrombocytosis.
Then?
And in case of intracellular shift, potassium shift of acidosis or heavy exercise, and beta blocker, insulin deficiency, and in case of hyperkalemic periodic paralysis, and also in case of increased potassium load through the food supplements, potassium rich food, and also IV potassium, and transfusion of aged blood.
Okay.
And in case of hemolysis, in case of GI bleed, and also in case of rhabdomyolysis, stomalysis syndrome, and also extensive tissue necrosis, and decreased potassium excretion in case of renal failure, drugs like beta blockade, calcium channel blockers, and potassium sparing diuretics, cyclosporin and tacrolimus.
These are the drugs. Any other drugs? Digoxin is there.
NSAIDs and
NSAIDs are there. So how do you treat a patient coming with a digoxin toxicity with hyperkalemia?
In case of previously there was studies like we can't give calcium gluconate, but now it can be given with caution.
With caution you can give, but
in slow dose.
Yeah, slow doses. Okay.
And also in case of aldosterone deficiency, also hyperkalemia.
Okay. So any other drugs which like we give in CLD patients can cause hyperkalemia? Spironolactone. So does octreotide causes hyperkalemia? Can cause. Okay. Then
we shifted the patient to the ICU and further management with the dialysis for in case of this refractory hyperkalemia. And the patient now in ICU.
Now the patient is in ICU, and how much of drop of potassium was seen? Like following the management, initially management.
Initially it was 8.1 and it dropped into 5.1.
Okay. So like can you tell me how much of pH will change according to the change in potassium?
0.1 change in pH, there will be 0.6 change in potassium.
Okay, fine. Okay. For this patient, initially there was little bit change. Later on, because of as patient was having significant higher levels of potassium and metabolic acidosis, we went ahead with dialysis. So this patient had any how was the anion gap of this patient?
Anion gap is 16.
Anion gap was 16. That is high anion gap or normal anion gap?
High anion gap.
High anion gap. So how do you calculate anion gap?
Anion gap is sodium plus potassium if it is included, or minus chloride.
Chloride and bicarbonate. So normally is 8 to 12 if you are not taking the potassium in value. If you are taking, it can little more increase, like 12 to 16, 12 to 15 will be the normal range if you are taking in account for the potassium value also in cases of high potassium levels. Okay. Can you tell me which are the normal high anion gap metabolic acidosis?
In case of salicylate poisoning and lactic high levels of lactate and
decay,
uremia, methanol.
Okay. Isoniazid. Okay. So in this case, you like patient had high anionic lactic acidosis with hyperkalemia. You dialyze the patient. So patient also had bicarbonate, right? Low. Will we give bicarbonate in this condition?
If there is any metabolic acidosis picture, we can give bicarbonate. If there is any cardiac impending cardiac.
So patient in cardiac arrest as such, we can give bicarbonate. Or else in severe metabolic acidosis, use with caution, but there can be like difficulties. So how much is the dose that can be given in cases if we are giving, we have to give slowly, very slowly. You have to give. Otherwise, you can give over 5 to 10 minutes bicarbonate. Or else, if you are giving in cases of severe metabolic acidosis, you have to give very slowly. Okay. So yeah, dialysis you have given, and any other drugs that can be given in case of hyperkalemia? Any other drugs that can
binding
be
agents?
Oral binding agents. Okay.
Paclitaxel or sodium circonate cyclosilicate. But their onset will be very slow. So that in case of acute hyperkalemia management, we can't give oral binding agents. And also while giving sodium zirconium, we have to cautious that if there is any constipation or GA symptoms, it will be difficult to give that because there is a chance for GA necrosis and all.
And how about like Lasix, furosemide? Diuretics can also be.
If the patient has adequate urine output and if there is any features of volume overload, we can give diuretics.
Diuretics can also be given. Okay. So yeah, that's it, right? About any other things you want to explain? You have talk about normal cases of causes of hyperkalemia, pseudo hyperkalemia. Like what are the clinical features that a patient can come with hyperkalemia? What are the clinical features that you see?
Patient has dizziness, syncope, and muscle weakness can be there. Muscle pain, paresthesia can be there.
Okay. How is the paralysis in hyperkalemia? Is it like ascending, descending?
It can be ascending.
Ascending paralysis. Okay. So yeah, anything else? Yeah.
We can also discuss about bradyarrhythmias.
Yeah. So this patient had like bradycardia, right? Complete heart block. So can you like tell me about regarding the heart blocks, like first degree, second degree, third degree heart block? Differentiate it, can you?
First degree heart block, there will be PR prolongation, but P is followed by QRS. And in second degree heart block, it can be divided into type 1 and type 2. In type 1, there will be progressive PR prolongation will be there, and it is followed by a drop in QRS. But in second degree, the PR prolongation will be there, but the PR interval will be constant with a drop in QRS.
Drop in QRS will be there.
And in third degree heart block, the PP interval and RR interval will be constant, but there is no association between P and R, and the number of P's will be more than the QRS.
Number of P's will be more than the QRS. So a patient coming with like heart block rather than hyperkalemia, how will you proceed? If the patient is having instability, you will manage with initial atropine.
With atropine.
How many? 3 times you will give, right?
3 times.
Okay. Following, if the patient is still in bradycardia, what will you do?
We can start on dopamine infusion and adrenaline infusion. We can start on
dopamine or adrenaline infusion.
Dopamine doses 2 to 20 mcg per kg per minute, and we can titrate according to the heart rate.
Okay.
And epinephrine we can give 2 to 10 mcg per minute, and we can titrate.
And other than that,
if there is any other cause like beta blockers or toxicity and all, we can give glucagon. Glucagon dose is 3 to 10 mg IV infusion over 1 to 2 minutes, followed by continuous infusion of 1 to 5 mg per hour. And we can also, if it is refractory bradycardia, we can proceed with pacing.
Okay. What kind of pacing?
Transcutaneous
pacing. And if still the patient is in like bradycardia, what will you further do?
Transvenous pacing can
Transvenous pacing can also be tried. Okay. So this patient can have like multiple causes, and you have to evaluate for the same. What are the dialysable drugs that can cause not that's hyperkalemia? Dialysable drugs. Which are the dialysable drugs? Barbiturates are there. Lithium. Isoniazid is there.
Salicylate.
Ethanol,
Theophylline.
ethanol, methanol. Okay, fine. Yeah, fine. Anything else?
In case of transcutaneous pacing, we can establish the electrical capture. For that, we can pace spike associate with the appropriate ECG response, such as QRS complex. And once the electrical capture occurs, we can also done mechanical capture by demonstrating the palpable pulse. And also we can adjust the pace rate also. And in this case, we have to do the disease-specific therapy in reversing the toxin-induced bradycardia. So in this case, we have to done the treatment of hyperkalemia, followed by dialysis because of the refractory hyperkalemia.
So anyway, you will need to do dialysis to, as this is the cause for the same, you have to do dialysis to reduce the hyperkalemia and make the patient in a stable condition, right?
Yes.
Okay. Anything else? Yeah. Okay. Thank you.